Good afternoon. My name is James Campbell, Leader 620. This will be my strategic presentation for Memorial Hermann Healthcare. Memorial Hermann has a strategic plan, and it is committed to investing in the health and well-being of all our patients and ensuring that healthcare programs and services are available to everyone. A key piece of this commitment is enhancing access and reducing wait times for our patients in our emergency departments throughout the system. Currently, Memorial Hermann operates 9 different hospitals with about 7 different convenient care centers. So they're very active in their emergency departments. As clinical manager, I plan to present the Memorial Hermann strategy to reduce emergency department wait times. As Memorial Hermann's mission statement, we are a non-for-profit community-based hospital, community-owned hospital, with spiritual values dedicated to providing high-quality health services in order to improve the health of the people here in Southeast Texas. In looking at this, I chose to use a couple of methods. I used a SWOT analysis initially, and what I found was we had quite a few strengths, yet we did have some weaknesses and some opportunities along with some threats. Some of our strengths were we had outstanding medical staff. We're very strong in our community as a leader. Proficient medical staff, up-to-date medical equipment, a variety of urgent medical care, including many different specialties. Competent medical staff, strong, and our biggest thing to me is a strong relationship with our EMS partners. Now, some of our weaknesses are we're under a lot of competition, as probably as many other ERs are, with freestanding emergency rooms. We currently do not have a trauma designation, and excuse me, we are fighting daily in the emergency department trying to get patients back in a timely manner. We're limited with nursing staff, and our LWBSs, which is left without being seen, and our left without triage are climbing through the roof. Some of the opportunities are that will help us is, 1 is achieving magnet status, 2 is getting that trauma designation. Currently there is no trauma designation. I do know we're working towards a level 3. And increasing our patient SAT scores, which I do believe wait times in the lobby, along with what we see is anytime we have a patient that waits in our lobby greater than an hour, they're more on a Press-Ganey scale of 1 to 5. They're more than likely to give us a 4 and not a 5, and basically that's like giving us a 0. It doesn't count, so it keeps our numbers real low. Our threats to us right now are, again, the freestanding emergency rooms, and we have a neighboring facility that's less than 3 or 4 miles from us, and we all are fighting for the same type patients. I also looked at ER data. Currently, Press-Ganey is the tool we use for collecting patient satisfaction throughout the hospital, whether it be HCAHPS or our own emergency numbers. Our current goal is to hit 80% in the ER. We're not making it. We're currently at 68% for the year, and for this month we're sitting on 56. Now to the LWATS, which is left without triage, which is never good for any emergency department, because that means you have patients that are literally walking out that haven't been triage, much less seen by a provider. The goal there is 0. Currently, we are at 4%, and this is running pretty much monthly. Our left without being seen, or many people call it LWBS, our goal is less than 2%. Currently, we're sitting at 8.2%. We were at 12.6. The problem with the LWBSs and the LWATs is finance, along with nursing informatics, has looked at this pretty tightly, and they figure that every patient that walks out of the emergency room, not only is it unsafe, but it costs us money. and they look at about $2,000 a patient. So you can see, you lose 8, 10 patients a day over 30 days. That starts adding up real fast and affects the bottom line. The strategic goal is to decrease the wait times here in the ER. And to do this, we're going to have to work with our stakeholders, including our EMS partners, and I think above all, we're going to develop some type of fast track area. Bringing our EMS partners is key. We chart through Cerner, which is a Cerner product, and we use FirstNet for the ER tracking. There is a spot in FirstNet where we can actually, when EMS calls us, we can actually chart pre-arrival information, which will expedite their time to a room once they arrive. Prior to the last couple of weeks, this has not been used in our ER, even though it's been active for several years. Excuse me, screen went blank. Now, as far as the fast track, we have found that we have an area behind the emergency department that fits perfect, that allows us to send these ESI level patients that have an acuity level of, basically 3 through 5, which are pretty much your non-acute patients. 3 usually is your highest number of patients usually come in with an ESI level of 3. We take these patients and they're seen by, we have now a doctor out front which will see these patients, so that eliminates the L left without being seen. So they're seen right away, and small tests such as diagnostics tests such as maybe a simple lab or a simple x-ray are ordered right there and started. And these patients are placed back in a chair in a separate waiting room versus putting back in the lobby. Now this does require some communication up front, because you have the higher level acuity patients that are sitting in the lobby that don't understand why maybe somebody that comes in is going ahead of them. So communication is key with this. You just have to explain to these patients that you have a much higher acuity. You will require a bed, and you need to be seen by a physician and not a mid-level provider. On the finished level action plan, the design and patient flow in and out of fast track, that's the key thing. And we will use a cross-functional team, including all stakeholders, to develop this team, which will be frontline staff, patient access, nursing informatics. We will, here at Memorial Hermann, we use Six Sigma and black belts along with green belts to help us with our change agents and everything anytime we want to change a process. This comes in very handy, especially during a startup process. Our ER staff is key. They're the frontline people. We need to listen to them. They're there every day. They see things that other people don't see. Our education department is also key. We can start this education on this fast track area and the new charting process with charting the pre-arrival with EMS. This can be done on new hires during orientation. I spoke of the subject matter experts, which would be your nurse and informatics team and your Six Sigma and our change agents. We grow our own Six Sigma people here at Memorial Hermann along with our own change leaders. And above all is the leadership team. Our leadership team has to be on board with everything we're doing. Now, as far as communication and getting this done, communication has to start from the top down. As far as flow process and metrics, these can be sent out daily. Our emergency department shifts have huddles every morning and every night before their shifts. We can go over the metrics then. Also, incorporating these subject matter experts again during the initial startup, where they're there beside the nurse that's doing all the charting and so they can better explain, and it makes a much smoother startup process. Feedback control model. Well, as we all know, without proper guide rails in place, feedback can start out as a scenic drive and end up as a giant fireball going over a mountain. Basically, we're going to be looking at our patient SAT scores. We use press gaining. There's 25 or 30 different questions we asked, and there's questions everything from everything on nurses, wait times, how clean was the room and lobby, uh, physician questions, likelihood of referral, and of course, we're all shooting for fives on these. Um, Also, I can pull the data for us left without being seen, and LWATS, which I do. I pull it every morning. This can be gone over with the physicians and the charge nurses and the staff in their huddles prior to shift. Actual performance metrics is what we'll be looking as we will here with Team Health is our physician group. We will be going over the current ED metrics, which involve door to doc, door to triage, uh, and those type of metrics. Including will be the LWATs, the physician satisfaction scores, the nursing satisfaction scores, acuity levels, the percentage of what type of patients we're seeing, and above all is our ability to stick to the process. That is key because if we can't stick to the process, it won't work. So we have to have this top-down communication coming from our leadership, and nursing staff, along with our techs and patient access clerks, have to understand this is what we have to do to shrink this lobby. It is no longer okay for a patient to sit out there. It is not safe. We've got to get these patients through here. We cannot let patients walk out of our ER. This is my strategy, my strategic plan for changing the wait times and improving the speed and flow out of the emergency department. I'm now open for questions.